This is an observational study on the association between sonographically detected anal sphincter trauma and fecal incontinence in the patients that I see every day. Oasis is common, we know that it's a common consequence of vaginal delivery, and the standard quoted prevalence figures, incidence figures of between 1% and 5% are a grotesque underestimate, which has been shown by a number of authors. The main risk factor for anal incontinence in later life is, in women, is oasis, so it's certainly worth looking at and worth diagnosing properly and hopefully preventing. Now, the first step in defining any kind of outcome measure, in this case a form of trauma, is to define the limits of normality. And in my unit, we've done a lot of that, and we've been obsessed with the limits of normality. So this study was about that again, determining what we can still regard as normal and what we should regard as abnormal. It's a retrospective study which ran over, which included patients seen over a period of a bit more than a year. They had a St. Mark's score, a POP-Q, and they had a 3D, 4D translational ultrasound. And Rodrigo analyzed over 500 women, over 500 data sets of such women to determine the limits of normality of appearances of the external and internal anal sphincter. We did that by using tomographic imaging, which you've already seen. This is obtained on pelvic floor muscle contraction with the transducer placed not vertically on the perineum as we usually do, but transversely and tilted in order to optimize depiction of the anal canal. Individual slices were rated as positive if there was a defect of 1 hour or more on the clock face, which is a definition that originates with Abdul Sultan using endoanal imaging. That's how we do it. We place a standard abdominal 4D transducer, which is the transducers used for perinatal, antenatal imaging. We place that on the perineum and tilt it downwards towards the anal canal, and the resulting image looks like this. I don't think you can pick it up. It's on the right-hand side. You see a donut shape or a bullseye shape with the mucosal star in the middle, then the dark ring of the internal sphincter and the bright ring of the external, and then the transversus perineum muscle is like the wings of a bird to the left and the right. And that's what the images look like. This lady here has a relatively minor external sphincter defect. So this is subcutaneous. This is at the level of the puborectalis, and there's a gap here in the internal sphincter which reaches to about here, and from there onwards there's sufficient continuity to rate it as normal. So these are defects of more than 30 degrees on the clock face, in this case only just barely so. So this rates as 3 out of 6 slices positive for the EAS. In this case, this lady has much more severe trauma. The external sphincter is virtually completely destroyed, so that donut shape has changed into a U shape. And in this case, I'm illustrating a defect of the internal sphincter, which is really small here, a bit larger here, reaching the cutoff of 30 degrees or 1 hour, and much larger here. And over here, the internal sphincter is completely open. It's not even a U. It's more like a shallow a boat. 501 data sets, which means we had 8% missing data. You can see the mean age there, body mass index parity. This is very much what is a very typical urogynecological population. 14% of them had fecal incontinence, and they reported a median St. Mark's score of 10, so quite substantial. We scored 6 slices, both for the EAS and IAS, which means Rodrigo did a total of over 6,000 individual assessments. We diagnosed EAS defects of any kind in 54%, and of those, 88 or 18% had defects in 4 or more slices, so what you saw on the right-hand side in that image just now. And the same was the case in 12% of our women for the IAS, that is 12% had 4 or more slices abnormal in the internal anal sphincter. We did logistic regression modeling to determine a cutoff for the diagnosis of significant external and significant internal anal sphincter trauma. That is, our definition of normal in this case is a definition that best distinguishes between asymptomatic and symptomatic. And you can see that that worked really well for the external sphincter, which is the model A. And I find it hard to believe these results. We went back twice. You can see there's this enormous step in odds ratios for fecal incontinence between 1 to 3 slices positive and 4 to 6 slices positive, which is really too convenient to be true. But of course, it agrees very much with Abdul Sultan's original definition of a significant sphincter defect on endoanal imaging, because Abdul rates somebody as positive for an external sphincter tear if 2 out of 3 of his 3 slices are positive. And that means 2 out of 3 agrees rather well with 4 out of 6. So what we did with that basically was, in a way, validate Abdul's original definition, which was more or less arbitrary or based on gut feeling. But obviously his gut feeling was working perfectly. Now, for the internal anal sphincter, there is an increase in odds ratios for fecal incontinence with increasing number of positive slides. And even controlling for external sphincter damage, the odds ratios are rather low, which surprised me enormously, because I thought the internal sphincter, for a while I thought the internal sphincter was more important. It's just that we weren't very good at looking for it and looking at it and diagnosing it. But, well, it does not seem to be true. So we found a high prevalence of both fecal incontinence and abnormalities of both the external and the internal sphincter in our urogynecological patients, who are seen on average about 25 years, 27 years after their first vaginal delivery, which is when most of the damage happens. Logistic regression modeling suggests that we should, if we want to define significant oasis on ultrasound, we should probably require that 4 out of 6 slices on such a tomographic representation have to be rated as abnormal. That is, they have to show a defect of at least 30 degrees of either the EAS or the IAS. The odds ratio, when we distinguish between those with 0 to 3 positive slices and those with 4 to 6, the odds ratio for fecal incontinence in those women with 4 to 6 positive slices is 18, very substantial and highly significant. This kind of condition, or this diagnosis, was made in 18% of our urogynecological patients, and that finding was strongly associated with fecal incontinence. The association between abnormalities of the internal sphincter and fecal incontinence was much weaker, and it's much more difficult to interpret, which means that, at least in our population, it is the external sphincter that is more likely to be responsible for continence or incontinence. Thank you very much.
Congratulations. I have one question. Do you believe that for positive abnormal slice of EAS lesion could predict patient to be submitted a PFMT to prevent fecal incontinence?
You're referring to the potential use of this postpartum. Yes, absolutely, absolutely. Of course, to prove that such any intervention in postnatal women actually works, you have to do an intervention trial. But if I could hark back to the first presentation today, there are trials now, like the PROLONG study, that look at the impact of an intervention in a more or less unselected group. I know, Suzanne, that you excluded stage 1, but to me that's still not very selected. And the same goes for fecal incontinence. It's obvious that childbirth does damage, much more than we thought. And it is also quite obvious that we should do something about this, isn't it? And there's primary prevention and there's secondary prevention. Primary prevention, well, people ought to stop doing forceps. It's as simple as that. Secondary prevention, that is what you were talking about. And in order to prove or disprove the efficacy of secondary prevention, it would make very good sense, at least initially, to limit intervention trials to women shown to be at high risk of future morbidity. That is how you design a study that has optimal power for the resources at your disposal. And that means, of course, it makes sense to diagnose avulsion and to diagnose sphincter trauma postnatally, and then target intervention to those women that are most likely to develop morbidity in the future.
Okay.
Is there a standard sampling distance between each slice? Because clearly a small tear, closer slices, you get more abnormals.
Very important point, and I'm sorry for not pointing it out. Very important point. With assessing the levator, we have a standard interslice interval because we cannot identify the cranial end of the levator. With the external sphincter, we can identify the cranial termination of the external sphincter. We identify that dorsally, where there's never any trauma. Unless a surgeon has done something really big there, it's always normal. Dorsally, that is towards the anorectal angle in the ischiorectal fossa. And at that point, we determine the cranial extent of the EAS, and we can determine the caudal end of the IAS, which is at the level of the subcutaneous part of the sphincter. And that means that, predictably, in every patient, we can slice virtually the entire EAS. However, people are different. Some have a lot of muscle and some have very little. And that means that the interslice interval has to be variable. We do 6 slices, or 8, from above the external to below the internal, and that may require an interslice interval of 1 millimeter in one person and 3 millimeters in the other. There's a lot of variation and something that we're working on right now.
Dr. Xiao from Taiwan, thank you for your presentation. I have one question. Do you perform multi-logistic regression for predicting external anal sphincter or internal anal sphincter to identify which is more important for the fecal incontinence? I mean, you have performed multivariate.
I'm not sure whether I understood, but if you're talking about the relative weighting of external and internal sphincter trauma, then the logistic modeling suggests that the EAS has a much greater weight in determining fecal continence.
Because you perform the multivariate regression analysis, sometimes the important internal sphincter defect, the rule will be diminished. Maybe, I don't know. Because it's important for repair the case of fecal incontinence. If the rule is only external, you can repair the external.
I'm not sure whether I understood, but you see, the St. Mark score has a number of different components. And an interesting question is whether different components of the St. Mark score, for example, fecal urgency, may be more related to one particular component of the continence system, and we're looking into that. And we can do that in 1,000 or in 2,000 women if necessary.
Last question, Mrs. Hagen, please.
Just a comment, really. Peter, to say that I totally agree with your statement about targeting of secondary prevention interventions, and although we included stage 1, although we included stage 1 prolapse in our trial, we'll do subgroup analysis to look at differences between the stages.
Yes, you see, from my point of view, stage 1, anterior and posterior compartment are part of the normal range. And we've got lots of data to show that. So if it's part of the normal range, then we should not call it prolapse. Yeah. Thank you.
Thank you.